I'm going to kick off the next section, which is around subscriptions and revenue guarantees. And the first speaker, I'm delighted to welcome Christine Ardal from Public Health Agency in Norway, and of course, a key person in the EU JAMRAI too, to talk about incentivizing member state participation. Thanks, Christine.
Thanks so much, Colm. So I'm a public health person, and we're here to talk about antibiotic resistance. So I'm going to take a step back a bit. First slide, please. I'm not sure that everyone in the room knows, but 71% or 71% of cases of infections with antibiotic-resistant bacteria are healthcare associated infections. That's from the ECDC. That is the case. 71% of resistant infections could be avoided with strengthened infection prevention and control measures. That's huge. OECD has calculated that investments in infection prevention and control and stewardship would pay for themselves within 1 year and produce savings of €1.5 for every euro invested thereafter. Next, please. So this is a best buy, right, to combat antibiotic resistance. Yet only 6 out of 28 EU EEA countries have actually operational national action plans that are financed. So that means that interventions like IPC are not being fully implemented due to a lack of national financing. And I think everybody here needs to understand that, because this is key. So we cannot talk about EU countries paying their fair share when countries are not investing in the dramatically less expensive and much more impactful basics of preventing antibiotic resistance. Next slide, please. So there is a disconnect here between the value of new antibiotics for countries and the amounts needed for to have companies invest in R&D. You can just scroll through, Frederick, thank you. So new antibiotics, as you know, are last resort antibiotics for the sickest patients. They should only be used when the older antibiotics don't work. And older antibiotics often, almost always, are still very effective. So if you look at the EU JAMRAI website, what I work on, you'll see that countries are trying to get improved access to older antibiotics from the 1950s, 1960s, 1970s. So don't let people tell you that the antibiotics are losing their utility. We're seeing increased resistance, but old antibiotics are still important. But for the sickest patients, we need new antibiotics. And clinicians don't know which ones will actually work, because they have to do susceptibility testing, and this takes time. In different European countries, it can take between 1 to 5 days to get the susceptibility testing back. So new antibiotics are given empirically, meaning before the testing results are back, waiting for those results. So ideally, clinicians want new and effective broad-spectrum antibiotics with no cross-resistance to existing antibiotics. Yet the current clinical pipeline is dominated by combination therapies, meaning you take an older antibiotic and you pair it with an incremental innovation to an existing class. 7 out of the 9 antibiotic candidates in late-stage clinical trials for critical pathogens are combinations. And this type of R&D is less risky since the company uses an existing effective antibiotic like meropenem, aztreonam, cefepime, which means that the combination product will likely result in a successful clinical trial. This means lower development risks and lower development costs, but this matches the current level of incentives. We don't incentivize for high risk development. So many of the incentives discussed today are continuing to incentivize this kind of combination product. They're not big enough to incentivize real innovation. And that's really what we need. We need new classes, we need new types of alternative therapies, and we need no cross-resistance. To get these products, we need incentives that encourage higher corporate risk-taking. Next slide, please. Because antibiotic resistance is a very serious threat. So, and you can see this from the latest, or one of the Health Security Committee meetings earlier this year in May, that we have Klebsiella, carbapenem-resistant Klebsiella pneumonia that's spreading rapidly throughout Europe. And one of the problems that they note in this is that countries are delaying administration of new antibiotics. Next slide, please. And why are they delaying administration of these new antibiotics? So if you look at this data from ECDC, you can see in the pink line the use of new patented antibiotics. You can see in the green line in the middle the use of monobactams like aztreonam, and then you can see the polymyxins to the far right. So the most common polymyxin is colistin. So colistin is an antibiotic that was discontinued in the 1980s because of toxicity. But now it's back and it's being used because we have to have something to treat these infections. So why aren't we using the pink line, the new antibiotics? Why are we using so much colistin in the EU? Well, I think we'll hear from colleagues at HERA in a couple minutes, but it's because they're not available. They're not widely available across the European countries. Thank you. Next slide. So we need a sizable revenue guarantee to promote true innovation. You've heard about many incentives today, but really we need a revenue guarantee to incentivize true innovation. Milestone prizes can probably help, but we need an EU-wide revenue guarantee. This is an economic incentive where the company that's developed the high-value antibiotic is guaranteed annual revenues by an organization like DG HERA in exchange for making the antibiotic predictably available in all interested countries. Countries continue to pay for their own national consumption. DG HERA would pay the difference between the revenue guarantee and the member state consumption. This is the only incentive that can be scaled up and down based upon the public health value of the antibiotic. And unfortunately, the new, as we heard quite well from Sophie earlier today, you can use a formula, but you still need to have clinical and public health competence to understand the value of these antibiotics. It's not formulaic. Maybe with AI we'll get there someday, but right now we're not there. So expert opinion is required. This is also the only incentive discussed today that ensures access in those countries paying for the antibiotic. Because quite honestly, without access, innovation is useless. We are developing these new antibiotics so they can treat life-threatening infections. They need to be accessible. I visited an EU country last week lacking access to almost every new antibiotic, including antibiotics approved a decade ago. They desperately want access to effective antibiotics, both old and new. Every country wants access to effective antibiotics. So an EU-wide revenue guarantee could incentivize this type of true innovation and access, and it can be scaled up to provide fair share levels. It can be paid out annually in manageable portions, not all at once, and thus you can also discontinue if you find out that the antibiotic doesn't work. There are a few, what I would say is high value new antibiotics in the clinical pipeline, but the preclinical pipeline looks pretty good. So we need to start looking and making sure that we're incentivizing the progress of these products. We can also reduce the cost of a revenue guarantee by continuing to invest generously in the preclinical R&D pipeline through organizations like CARB-X and GARD-P. But it is best that this is handled at the EU level, because then they can ensure the availability in all countries. So you've heard about a lot of incentives today, but the bottom line is that the EU can no longer be passive regarding which antibiotics countries have access to, nor what type of antibiotics that are being developed. The therapies that are needed are truly innovative therapies, new classes, no cross resistance, We need to have a future where these antibiotics will last as long as penicillins and cephalosporins and other antibiotics instead of taking existing antibiotics that are already developed. This has to be done at the EU level with pooled EU funding. At the member state level, priorities must be the most impactful interventions to reduce antibiotic resistance. And there's no doubt that that is infection prevention and control. You have to remember 71% of resistant infections can be avoided. 71%. And that means that no antibiotic is actually needed. Thank you.
Thanks, Christine. We will have opportunity for questions for Christine and the other speakers later, but next I'd like to welcome Jean-Baptiste Perrin from DG ERA to talk about the hurdles in setting up the pan-EU revenue guarantee scheme. Thanks, Jean-Baptiste.
Good morning. Indeed, so I would like to present the experience that we had in ERA, Health Emergency Preparedness and Response Authority, on the pilot multi-country revenue guarantee that we tried to establish. Next slide, please. So just as introduction to highlight that ERA is addressing innovation and access to medical countermeasure against AMR in a broad sense. And we have many actions ranging from priority signaling, strengthening surveillance capacities, innovation, access, with all this with an international dimension. But today I really focus on our pilot revenue guarantee to improve access to newly registered antibiotics. Also, just to highlight, we have published the medical countermeasure strategy in July, and this strategy includes a specific provision for AMR. Next slide, please. So first, as Alexandra recalled, the Commission has a strategy on pool incentive, and this was described in the communication accompanying the Commission proposal for a new EU pharma legislation and the Commission proposal for a Council recommendation to step up the fight against AMR in April 2023. And this strategy consists in looking at the toolbox of pool incentive to improve innovation and access to antibiotics. Antimicrobials. The first one is a transferable data exclusivity voucher for the development of new antimicrobials, and this we discussed extensively, but also to explore procurement mechanism to improve access to new and existing antimicrobials through revenue guarantee. And this was confirmed in June in the Council recommendation on stepping up action against AMR, where Commission was invited to design an EU multi-country pool incentive scheme to improve innovation, the development of new antimicrobial, and access to existing and new antimicrobials. Next slide, please. So with this scheme, we aimed to address the issue of accessing new antibiotics that have been developed and put on the market. And here you see an illustration of the lack of access to new antibiotics. So it's a bit dated. It was something published in 2022 and describing the situation in 2020. But on this slide, you see the list on the left of the new antibiotics, their date of first approval, often by the FDA in the USA, and then the number of days after which various countries at global and in the EU level had actual access to this antibiotic. And you see a lot of white space indicating where the antibiotic was not available at the time of publication. And as you see in the second column, the date of first approval, sometimes even 5 or more years after the first approval, the new antibiotic is still not available in some EU countries and other countries. And this, despite a commitment from the industry, you see below the FPR commitment in 2022 to commit to file for pricing and reimbursement in all EU countries for as soon as possible and no later than 2 years from the central EU market authorization. But this commitment proved to be particularly difficult for antibiotics, antimicrobials. Next slide, please. So how we prepared our pilot. So first, there has been a lot of report and resources describing the potential incentive that we can implement. And as mentioned, we had commissioned our own study, which include a simulation of the different scheme for pool incentive, including milestone payment, market entry reward, or revenue guarantee. This study is public. We also use the work of the joint action of member states, EU JAMRAI, and their report. Also, a very good policy brief published under the Swedish presidency on innovation and access to antibiotic. a more recent policy brief from the Drive AB consortium, and also the existing initiative on revenue guarantee at global level. So, you know, in the EU, we have one member state that carried out a pilot revenue guarantee, Sweden. Our colleague from UK are here today and presented a subscription model. We also have similar initiative for revenue guarantee that are explored in Canada and Japan, and we are in contact with these teams to develop our own scheme. Next slide, please. So on general principle and design, so first we work with some constraint on the framework that we wanted to implement, but the objective was to provide, maintain, or improve access to antibiotics that already have been developed, but that are still new and not accessible in all EU member states. And we wanted to do this without interfering with the member state competency on pricing and reimbursement, and that was a wish expressed by the member state. So we work at the EU level with a multi-country context where we don't have all the competency relating to medicine market approval, pricing and reimbursement. We also wanted to fund this project with EU budget, so not with the member state budget. And we mobilized for this the EU funding program, EU for Health, Work Program 2023. And the objective was to organize a call for tender, so a procurement, to pass a service contract between the European Commission and the antibiotic producer. The objective was to have a 3-year contract for implementation, and that will include 2 tasks. So the first task of 12 months would be to finalize the market launch in all participating EU member states, because we work in a context where some member states already have access to the antibiotics, some did not. Then to be able to kick off a revenue guarantee that will cover all the member states participating and where the antibiotic has been put on the market. And the main service requirement, because it's a procurement, we have to pay for a service. And then the service is to maintain the antibiotic on the market and to deliver to the procuring entity within 24 hours, which is important in this case because it's new antibiotic used on hospitalized patients with very serious condition, and often it's life-saving product that need to be very rapidly accessible. And it was also, for some member states, an improvement to their current contractual agreement with producer. In exchange to this service, we wanted to pay an annual payment of the revenue guarantee. So you know the principle. We provide this payment, but it's deducted. We deducted from this payment the profit from the sale, from the same participating member state, and also we deduct non-compliance with the contract. For example, if the product is not delivered to the procuring entity. The size of the revenue guarantee was similar to the one implemented in Sweden, proportionate to the market that we covered, but also in the limit of the EU budget that we had available for this action. It started with an overall envelope of 17 million, but then over the course of the process, we had an envelope of 40 million to implement this 3-year action, including the 1-year launch of the product and maintaining product during 2 years on the market. Next slide, please. About the implementation, we extensively discussed the prioritization of the antibiotic, and here we work with the member state and we let them prioritize the antibiotic that they needed among the ones that were approved in the last 10 years. And from this prioritization, there were a top 3 antibiotic that was very clear and shared among the countries that had expressed interest in the scheme. ERA engaged with the market authorization holder of the prioritized antibiotic to inquire on their own interest to engage in the scheme. And then the ones that were interested were invited to submit an offer based on tender specification. The market authorization holder submitted their proposal. It was evaluated by our executive agency, ADEA, also with their evaluator. And we were in a negotiated procedure, meaning that everything that I have presented was up for negotiation according to the constraint identified by the companies on the implementation of the contract. Well, not everything, but many aspects of the tender within the available budget, but they could negotiate the budget allocated to these 2 tasks, the timeline, the calculation of revenue guarantee, considering each different country participating. So the outcome of this tender was that finally the proposals that were submitted by the company after negotiation was validated by the European part, by the contractor, which was actually ADEA. We published the contract award notice, but finally, the company decided to not sign the contract corresponding to their own proposal due to a reason from their side on the issue with the validation of this contract. So finally, the offer was not signed and the pilot was not implemented. Next slide, please. So we are drawing the lesson learned of this experience. And first, we saw that we need to further discuss with member states the clarified desired access path for novel antibiotic. In this scheme, the objective in task 1 was to provide market access, meaning having as goal the completion of the full pricing and reimbursement procedure in all EU member states, and which was considered too burdensome for some novel antibiotic. In case, so it's antibiotics that are only hospital use in a very small volume. So there might be other access paths that can be temporarily possible, as for example, just the inclusion on the hospital list tender for this antibiotic that will allow a revenue guarantee to rapidly kick off without waiting for the pricing and reimbursement to be completed. We also are aware on the need to reassess the budget in view of the service that was asked, and also revise the potential allocation of the revenue guarantee among the different participating countries, maybe to have a higher revenue guarantee in smaller countries where the expected sales are lower, to make the scheme profitable enough for the company to engage. We had a lesson learned with our member state internally, but also with the industry. We organized a specific workshop in June with the company where we gather very useful feedback, and then notably highlighted the need to address non-financial hurdle, meaning even with funding, them are not necessarily able to complete this procedure in member states for pricing and reimbursement and to launch their product. And that's especially challenging for smaller companies. They also recall the need to further fund innovation, which in how we are well aware and do, and complement. Keep in mind the pilot was really aimed to improve access to new antibiotics that are already been developed, was not scaled in a manner that will incentivize innovation. And on this, our purpose was also to test the scheme and to validate the procedure, to also have the possibility to scale it up to another level if needed and if considered for innovation. Next slide, please. We also identify that we need to further work with companies to overcome business secrecy and confidentiality. We rapidly saw there were concern on sharing the data that we need to calculate the revenue guarantee at EU level, and there is difficult for them to share the expected demands, the price that are planned, the rebates and discounts that are negotiated with member states, which make the work at multi-country level very, very difficult. Nevertheless, the industry was still positive that if such scheme is implemented, this concern can be overcome. Another major issue that we face in a company willing to engage with us was the existence of pre-existing contract and agreement, notably with distributors or patent holder, which meant that the global rollout plan was already finalized when we start engaging and proposing the contract, and that they could not change this contractual engagement to accelerate the rollout. Next slide, please. So that's the lesson learned. We're still in the process of gathering this information. The budget for this action is not available anymore, so we are not able to relaunch a similar action. We will discuss with member states in the upcoming ERA board, so it's a specific governance body of ERA where we exchange with member states about the next step. We have to say the overall feedback on the process was rather positive from the member state, also from the industry, to try to explore this approach, despite the negative outcome. So we definitely will continue to support innovation through the push funding action that we have, and we have a lot of exciting projects in this area, and continue exploring procurement-based incentives to speed up and maintain access to newly registered antibiotics.
Thanks very much, Jean-Baptiste. I'd like to call on David Glover from NHS England, who's been key to the delivery of initially the pilot project in England and then bringing on board the other home countries in the United Kingdom into the full UK subscription model. So David's going to talk us through some of his experience with that. Thanks, David.
Thanks very much, Colin, and thank you everybody for the invitation to join you today. So as Colin says, my name is David Glover. I'm a health economist by background working at NHS England. For those that don't know, NHS England is an executive body that sits at the apex of the health system in England. And as Colin said, along with colleagues from NICE who have spoken today, responsible for the development of the pilot and then evolving that into the subscription model scheme that got launched in August last year. So in this slot, I'm going to talk to you a little bit about the experience of moving from the pilot, which was an England-only scheme, so just our own healthcare system, to one across the whole of the UK. And for those that don't know, obviously the UK is one country, but it has a devolved political system, England, Scotland, Wales, and Northern Ireland, where each of those nations are responsible for the healthcare system in their own nation. So if you just move on to the next slide, which is my sort of sole slide really. First of all, just talk a little bit about the cooperation and engagement that we did to get the scheme running. So the first element really of that necessarily is political. So in practice, what that meant was getting each nation to agree to the commitment within the national action plan that we have in the UK for the development of a subscription model and for participation in it. Once we had that commitment generally, that then meant the next step was to get the health minister from the UK government to write to their counterparts in the other nations, inviting them to participate. So that was kind of, sounds quite straightforward, but obviously you can imagine there's quite a lot of discussion to get to that before the commitment is made. Next step was to have a discussion at the clinical level, and the forum that we did that through was the chief pharmaceutical officers. So each nation has their own chief pharmaceutical officer. They were largely very supportive of the scheme in principle. And again, they wanted to understand what the implications were for their nations of participating, particularly the financial implications. Once we got through that, we just moved on to regular planning meetings at officials level, and that resulted in a memorandum of understanding that sets out the roles and responsibilities. Now, I think that was quite important for us because it makes sure that we know what we're supposed to be doing, and it also makes sure that really people can't move backwards from whatever position we'd agreed. So that was kind of the cooperation and responsibilities. It's worth noting that that memorandum of understanding is not contractually binding, but it's quite common within the public sector in the UK between different public sector organisations to understand what we're supposed to be doing. So then to get the one subscription model to work across the 4 nations, there are a number of principles. So there is a single procurement process across all 4 nations. That means the companies only have to fill in one application form. Each nation is a contracting authority. That is procurement speak to means that they are party to the contract that we end up with. So we don't have one country, for example, acting on behalf of all the others. Each are acting separately and independently. And that also means that we have nation-specific contract performance indicators within the contract. So just going back to what we heard about access issues and the delivery around what was required, we have separate ones for each of the 4 nations. So for example, in Scotland in particular, where the hospitals may be in a more rural location, the need to deliver product within 24 hours is not as strict there. So they have more like 48 hours to deliver the product, whereas in England, it's more 24 hours. So there's the ability to flex whatever performance criteria we have between each of the nations. But we also agreed that once the contract is in place, it would only actually be managed by one nation. So the company would, so one nation would do the administering. The company would only have to attend one meeting, although we'd have representatives from each of the nations at each of those. What we also agreed, which was quite important to get it to work, is that one nation is not financially liable for payments of the other nation. So although there's one contract, if, for example, England was behind on their top-up payments, that would mean that Scotland wouldn't have to pick up any of the liability. So again, that was important in terms of getting things to work. Operationally, as Sophie said in her presentation, there is the eligibility and evaluation criteria. Each nation has input into the discussion around those and will agree to them before each procurement process is launched. As I mentioned earlier, each one nation acts as a lead authority. And one of the questions I had was the incentive to get other nations to join in? Well, England volunteered to do all the administrative work, so other countries didn't have such an administrative burden to participate, but nonetheless, they maintain their ability to make independent decisions. Also, there is one assessment process, which is led by NICE, so we needed to get agreement that the other nations would recognise and accept the output from the panels being chaired by, being commissioned by NICE, and that means that we have consistency then across making sure that the products are all placed into the same value band within the contract. So that's all my comments, and happy to take questions. Thank you very much.
Thanks very much, David. I'm very conscious that we're a bit behind time, but it's a really important topic. So I suppose just kicking off the questions, I suppose, to Christine and Jean-Baptiste. I mean, how can the EU incentivize participation in a multi-country subscription model? What are the key steps really from now going forward?
Well, I think from maybe Jean-Baptiste can talk about participation, member state participation in the scheme that you went through.
Yes, so among the lesson learned, as I mentioned, even though the outcome was negative, the feedback and the interest of member states was positive, and the interest was really high. And I think there is really the will from member states to continue further explore this type of scheme with the Commission. In ERA, we also mobilize other type of procurement. So this one was a service contract passed by the Commission with the antibiotic producer to mobilize EU funding. We also mobilize joint procurement in ERA to purchase medical countermeasure. Through joint procurement, the Commission negotiates on behalf of member states, but member states purchase the service or the product on their own budget. So there are many things that we can explore also in terms of mobilizing member state budget in combination with the European budget. Also look at joint procurement, whether it will be also a tool of interest to improve access. So I think there are many options we are currently discussing and exploring.
Enrico Beraldi.
Yeah, if I understand correctly, it was a matter of the company that was thought to sign the contract refusing to do it?
So I think also context-wise, we had a tight deadline. They had tight deadline to make important decisions. They had submitted a proposal that we have validated, and they didn't get all the approval that they needed in time to validate their own proposal, which for them was also difficult to establish and to have all this rollout plan and budgeting and making the proposal of revenue guarantee. Even from the company side, it was challenging to really assess that the proposal was aligned with the cost of the action and that the revenue guarantee was properly set.
Super.
But I think it's important to say that a tremendous amount of progress was made in this process, and so so a tremendous amount of progress was made, and to abandon it when we've already, we can't. I think the thing is that we've got to give it another shot, and the budget was fairly modest. So, we're talking about 400 million for a voucher, whereas, 40 million for a revenue guarantee. So I would hope that there is interest on behalf of European countries to try again, because, It's something that's developing more maturity, and there are more products. And really, if you think about the difference between a subscription model and a revenue guarantee, at a certain level, as long as you're looking to incentivize innovation, there's no difference.
Right, thank you very much. It doesn't look like we have any questions online at the moment. And again, just conscious of keeping on time. I'd like to thank all our speakers for that section. Thank you very much,